Welcome, everyone. I hope you had a good break. I'm happy to start the next part of the session today, where we now will discuss the guidelines on hypoparathyroidism from the European Society of Endocrinology. I'm Liesbeth Winter. I'm internist endocrinologist in Leiden University Medical Center, Leiden, the Netherlands. And as a clinician, I mainly focus on bone diseases. I'm also involved in the PARAT initiative, so the educational program on parathyroid disorders. And I will share with Teodor Dumitrescu. He is based in Bucharest, Romania, and he's father of a 3.5-year-old girl suffering from hypoparathyroidism. I'm happy to announce our first speaker, who is a very well-known clinician and researcher in the field and has of parathyroid disorders, has contributed a lot. It is Jens Bollerslev. He is Professor Emeritus of Endocrinology at the University of Oslo, Norway. He has done a lot for the European Society of Endocrinology. So he was member of the executive board from 2013 till 2017. He was chair of the ESE Education Committee 2014 to 2017 and chair of the ESE Committee for Postgraduate Courses from 2015 till 2019. Presently, he co-chairs this PARAT initiative from the ESE, and he just completed his role as co-chair on the revision of the ESE clinical guideline on the management of chronic hypoparathyroidism in adults. He's doing research in clinical and translational endocrinology, also in classic endocrine diseases, but always with a main focus on bone as a target tissue for the activity of the disease. He has published many articles in peer-reviewed journals. And I think we're very happy that he is willing to update us now on this very new revised guideline. So I will hand over to Jens Bollerslev. Thank you.
In this session, we're going to discuss the revised ESE guideline on treatment of chronic hypoparathyroidism in adults. First, I'll give you the background as seen from the clinical point and the scientific point. And in the later part, Lucy will discuss the same guideline based on patient perspective. Ten years ago, the Society presented 3 clinical guidelines at ECE in Dublin. One of these were the ESE guideline on treatment of chronic hypoparathyroidism in adults. Over the past decade, we have learned a lot on how to manage chronic hypoparathyroidism, but also on the patient burden, on the comorbidities, and the long-term perspectives. Thereby, it was timely for the clinical committee in 2023 to decide to do a revision. A task force for doing this revision was established. Olaf Deckers was appointed as the methodological chair and I as a clinical chair. As you can see from the slide, several well-known experts have all joined the task force. We also had representative from the nurses. We had a representative from the ESE, that is the European Surgeon Society. We had a nephrology Pascal board, and also an American Endocrine Society representative, Carl Palais. Moreover, ICE was represented by Luis Cardoso. By that, the task force was appointed by the clinical committee, and all proposed stakeholders involved in preparing medical guidelines filled in, signed, and returned the declaration of interest. It should be said that not all appointed members of the task force was immediately accepted by the clinical committee, wherefore some substitution had to be done. Finally, the clinical committee approached each of the candidates for the working group, as you saw in the previous slides. So what is chronic hypoparathyroidism in adults? We're just talking about adults. It is by definition an orphan disease with a prevalence of about 6 to 40 per 100 inhabitants. It is mostly secondary to neck surgery and with a female preponderance. By definition, chronic hypoparathyroidism is a two-hormone deficiency state, PTH, and secondarily also 1,25-hydroxy vitamin D, activated vitamin D. As said, the condition has a very high morbidity burden. And recent estimates from Scandinavia points towards for up to 40% of all patients on social benefits. And these are often young patients. Thereby, it's not only a burden for the patients, chronic hypoparathyroidism is also a burden for societies. As said, the definition, it is a two-hormone deficiency state. As you can see on the slide here, when you lack PTH, most often as secondary to surgery, you will lack the effect of PTH on the receptor molecules. These contact molecules for PTH is spread widely in the body. Almost all tissue, not to say all tissues, has PTH receptors. Without the hormone, it doesn't work. Thereby, bone turnover is turned down. It's not possible to mobilize calcium from the calcium bank in the bone. PTH regulates very efficient the excretion of calcium in the kidneys. Without PTH hormone in the tubules, you will have a major loss of calcium out in the urine. Moreover, PTH activates 25-hydroxy-D to the activated form 1,25-dihydroxy-vitamin D. In turn, activated vitamin D increases the calcium absorption from the gut. In total, lacking the hormone, you cannot mobilize calcium, you cannot reabsorb calcium in the kidney, and you cannot, via vitamin D, absorb calcium from the gut. Thereby, we get low calcium levels. Over the decades, and I'm going to illustrate how the treatment has developed over the decades. Primarily, we have been talking about an indirect treatment, not a systematic substitution by the hormone. If we look back to the 80s and before the 90s, the treatment was huge dosages, huge doses of native vitamin D, plus calcium supplements, also in high dosages. This was because at that time, activated vitamin D analogs did not exist. From the 90s to the present, activated vitamin D analogs have been present. They are costly and thereby not affordable for all over the world. But if you use activated vitamin D, you can reduce the calcium supplements, and often you can be treated only with calcium in the diet as in other people. Moreover, you will give native vitamin D as in the background population, ensuring that you have a sufficient vitamin D level in your circulation. Magnesium comes in as a supplement. Magnesium often do follow calcium, and thereby we will also give magnesium supplementation. By this, I like to call it first-line treatment, or in the literature, conventional treatment. When we come to replacement therapy, in the zeros, small clinical trials were performed, often initiated by the investigators, and using PTH 134, which is a fragment of the entire PTH molecule with high affinity for the PTH receptor, but also a relatively short half-life. It showed benefits versus standard, thereby indirect management. Systematic studies were then performed in the tens. Clinical trials in different design, primarily with whole molecule PTH, having a little longer half-life, thereby having a little longer period of action in the body. Also, studies investigator-initiated or initiated by the pharmaceutical industry. These studies showed improvements in pill burden and biochemical markers, and potentially also in quality of life. In 2015, PTH 184, whole molecule PTH, was approved both by FDA and EMA. However, as you know, it was withdrawn from the market in 2024. At the present stage, in the 20s, systematic studies with Palopec teriparatide, Palopec, has been performed with clinical benefits, including pill burden, clinical outcomes, and biochemistry. PTH in the form of Palopec teriparatide was approved by EMA and FDA for clinical use in just a few years ago. Other compounds are in clinical trials, yet not approved. So that's where we are today. So what do we present in our revised clinical guideline on management of hyperphagia? In total, we present 37 recommendations on diagnosis, the general goals of management, treatment, monitoring, and special circumstances, for instance, pregnancy and lactation. So what's new? Everything is new. We have been over the whole guideline, revised it. Every sentence has been looked at, has been developed further. So we established 3 clinical questions. First, when to diagnose post-surgical hypoparathyroidism. What you see here is an extensive literature search and synthesis of the results going up, looking at when to define clinical or post-surgical hypoparathyroidism. About 40% of all patients undergoing anterior neck surgery do present some symptoms of hypoparathyroidism in the postoperative phase. However, most of them will recover. So about 80% will have recovered when we come to 6 months out. That was the definition point in the first guideline. But as you can see in the slide here, further patients, a significant amount of patients, will in the following 6 months also recover. Thereby we defined chronic hypoparathyroidism in adults at the 12-month time point. Importantly, recovery can be expected even later. Therefore, it should be checked for regularly in ongoing monitoring. Clinical question 2, first-line conventional treatment. Our literature search gave us that solid data for conventional treatment, first-line treatment regimes are lacking for clinical relevant endpoints, such as biochemical control, quality of life, and long-term effects. Same clinical question, optimal treatment of chronic hypoparathyroidism in adults, PTH replacement therapy. At this point, it is clear that PTH replacement therapy reduces the pill burden of conventional therapy. It improves various biochemical parameters and potentially improves quality of life. Importantly, we recommend initiating PTH replacement therapy in patients who continue to have signs and symptoms of hypoparathi despite optimal first-line or conventional treatment. We do acknowledge that PTH replacement therapy might not be available for all patients and all over the world. Our clinical question 3, a potential role for parathyroid transplantation. The literature was reviewed, but proven to be very low. Thereby, this option is not recommended in general. In conclusion, we provide you recommendations for the diagnosis, management, and monitoring of chronic hypoparathyroidism in adults in order to give patients and healthcare providers practical guidance on the management of chronic hypoparathyroidism in adults. The guideline can serve as a source for preparation of educational material to empower patients and clinicians. In the upcoming edition of the Endocrine News that will come within a few weeks, you can read further on how we have made this work and how we do present it, including an interview with Leonie and me. So thank you very much for your attention. And now we will proceed with the patient's perspectives by Lucy, and we will have a discussion afterwards. Thank you for your attendance.
Thank you for that. It is my pleasure to introduce Lucy Weigall, Joint CEO of Parathyroid UK. Lucy is a 33-year-old office manager living in London. She understands hypoparathyroidism not as an abstract diagnosis, but as a lived reality. Following thyroid surgery in 2020, she was diagnosed with hypopara and has endured the relentless challenge of managing chronically low calcium levels, including many emergency hospital admissions. From that personal struggle, she has channeled her experience into co-leading Parathyroid UK, a volunteer-run charity dedicated to supporting people living with hyper and hypoparathyroidism. Though my 3-year-old daughter, who is a hypopara patient, and I live in Romania, we benefit from the advocacy, the resources, and community that Lucy and her team create. They remind families like mine that we're not alone. Please welcome Lucy Weigall.
Hello everybody, my name is Lucy and I will be talking on behalf of Parathyroid UK today about the patient view on the new ESE guidelines. This was written by Liesbeth. So in 2015, the first clinical guidelines for the treatment of chronic hypopara were published. The patient groups who had formed the European Hypopara Network collaborated with the ESE to produce an accompanying patient information leaflet, which some of you, I'm sure, will remember. Apart from the leaflet published by the UK Patient Group in 2010, this was the only other publication available to patients at the time. It was good to have the first ever clinical guidelines, and these have been the gold standard ever since, yet patients did not contribute and felt more was needed. 10 years later, the guidelines have been reviewed. The same patient groups, now all affiliated to the ESE, collaborated over this last year to provide input to the development of the newly revised guidelines at the request of the steering committee to ensure that the patient voice was taken into account. So, what has changed in 10 years? In general, we're delighted with these guidelines. Based on the up-to-date scientific evidence, they clearly show how much has been learned about the impact of hypopara since the first publication 10 years ago, and also how attitudes to patients have changed in the time. The guidelines will give a better understanding to those doctors who don't see many cases, and we hope will end some persistent myths about treatment of goals and patient need. Post-surgical hypopara is now defined as persisting more than 12 months following surgery. Recovery can be expected even later. It's acknowledged that patients with chronic hypopara experience a lower quality of life, characterized by musculoskeletal and neuropathic pain, fatigue, weakness, increased anxiety, and a potentially higher risk of depression. We're especially glad to recognize the variety and severity of this condition, the difficulty in managing labile calcium levels, the inclusion of dietary calcium, pregnancy and lactation management, and updated recommendation for goals of management and treatment, including PTH. Post-surgical hypopara should be defined as persisting more than 12 months following surgery. Recovery could be expected even thereafter. So, firstly, diagnosis. Blood test results showing low calcium and low or normal levels of parathyroid hormone are needed to make a diagnosis. Interestingly, it's stated that ionized calcium measurements might improve diagnostic accuracy, which may be useful in pregnancy in those with brittle or very unstable levels. Also, magnesium depletion impairs the secretion of PTH, so if magnesium levels are low, this should be corrected before diagnosing a patient with chronic hypopara. For those with non-surgical hypopara, if no other evident causes, they and their family can be referred for genetic testing. Finally, due to new evidence showing increased recovery rates after 6 months, chronic hypopara should no longer be diagnosed within the first year following surgery. Previously, this was 6 months. So the general goals of management in hypopara. This is a really important point which recognises the treatment needs to be tailored to the individual. It's an incredibly individual condition. It focuses on treatment goals which aim to keep calcium levels in the lower part of the reference range in order to achieve fewer symptoms, better long-term outcomes, and a better quality of life. We're really pleased to see that it validates what we as patient groups strive to do, and that's empower patients to better understand their symptoms, what they mean, what to do about them. Self-management is a vital aspect of this condition, but it's really not easy. The ESE patient leaflet and emergency cards are referred to, and I'm sure that the patient groups will be writing new information based on this guideline too. So the suggested goals of management. Suggestions are not as strong as recommendations, but still important and are particularly useful if management problems occur or levels are unstable. These show the need to keep phosphate, magnesium, and 24-hour urinary calcium levels to be maintained within normal ranges, and for vitamin D to be maintained at above 75 or 30. This last is worth noting, as this level is higher than the normal equated 50, and is often refused by consultants who believe we get all of our vitamin D needs from our active vitamin D, alpha-calcium or calcitriol. Treatment. Here, treatment is recommended if you have symptoms of low calcium and or low calcium levels under 2. This is a really important change. Suggests you can try treatment if your levels are between 2 and the lower limit, even if you don't have symptoms, to see if it will make you feel better. The idea that treatment is not set in stone and can be flexible according to individual responses is extremely helpful to patients who may be struggling. However, data is still lacking on clinically relevant endpoints and long-term effects in conventional treatment. Calcium. So for the first time, we're seeing the importance of dietary calcium in hypopara taken alongside active vitamin D being recognised as a treatment, and calcium supplements need only be used if that doesn't suffice or as occasional bump ups. The body can only absorb 500 milligrams of calcium at a time, and that can be spread over the day, and that's been acknowledged, which is amazing. While patients have been doing this for a long time, the recommendation will hopefully help to prevent the still common overprescribing of calcium supplements and underprescribing of active vitamin D, which can lead to so many hospital admissions. Most importantly for us, however, is the reasoning given, and I quote here, that some patients may require higher calcium levels for symptom relief. If raising calcium levels to the upper part of the normal range improves well-being, this may be acceptable, as there is no evidence of specific harm from this approach. However, the elevated calcium level resulting from conventional treatment comes at the expense of increased urinary calcium excretion. It is important to emphasize that no firm evidence exists on the long-term benefits or harms of achieving these therapeutic goals. Consequently, treatment decisions should avoid compromising quality of life or imposing significant burdens on the patients, such as undesirable lifestyle changes or adverse effects of therapy. Finally, a reminder that calcium also binds with phosphate, so calcium supplements may be useful for certain people with high phosphate levels. PTH. It's really great to see PTH treatment recommended at last, and this is the most significant change in the guideline, which states that PTH replacement therapy reduces the pill burden of conventional therapy, improves various biochemical parameters, and potentially improves quality of life. The guideline recommends PTH for patients who remain symptomatic despite optimized calcium and vitamin D therapy, but states that where available and affordable, PTH replacement therapy should be considered for patients not adequately controlled on conventional therapy and based on the individual needs of the patient. The guideline goes on to suggest further criteria that qualifies a patient to receive PTH. It should be noted briefly that in this section, the guideline does not yet recommend parathyroid allotransplantation as a treatment. This is a surgical procedure that involves implanting parathyroid glands from a donor, unlike autotransplantation, which replants the patient's own tissue and which many patients would like to see done routinely. Hypocalciuria. In the presence of hypocalciuria, we suggest measures to lower urinary calcium excretion, which may include decreased doses, a low sodium chloride intake with a thiazide diuretic. If these measures are not effective in normalizing hypocalciuria while maintaining calcium levels within the target range, we suggest PTH replacement therapy. So if these measures don't work, then PTH is suggested. A new and important statement. Renal damage is one of the most common and serious outcomes for hypopara patients, and we know that PTH therapy can improve renal function. No data is available on whether thiazides reduce the risk of renal complications in hypopara. If a thiazide diuretic is prescribed, it should be noted that the hypocalciuric effect is dose-dependent, and treatment should preferably be combined with sodium restriction. A relatively high dose administered twice a day is often needed to lower 24-hour urinary calcium. Hyperphosphatemia. This is again a new and important suggestion with PTH to be used as a secondary treatment after conventional treatment has failed. Magnesium and vitamin D. The importance of magnesium in the body means there's a recognized need to keep magnesium in the reference range, and despite the inadequacy of serum testing, monitoring is advised and levels should be optimized in hypopara. Regarding vitamin D, it's good to see in writing that treatment with activated vitamin D analogues does not guarantee an adequate vitamin D status. So with monitoring, we suggest monitoring PTH levels once a year, and we recommend routine biochemical monitoring of circulating levels of ionized, albumin-adjusted calcium, phosphate, magnesium, and creatinine. EGFR as well. This is really great to see, as we often don't see a consistent approach to the monitoring of PTH, of hypopara. As before, extra monitoring is recommended following adjustments in medication, though this still may not be enough in unstable cases. So, special circumstances. Autodominant hypocalcemia. We recommended close monitoring of patients with autodominant hypocalcemia who are being treated with calcium and or activated vitamin D, as such patients may be at greater risk of hypocalciuria and renal complications. Many of our hypopara members have successfully become new parents, but it's not without its challenges. Becoming pregnant causes production of activated vitamin D, as well as parathyroid hormone-related protein by the placenta, which increases as pregnancy progresses, causing higher levels of urinary calcium. This PTHRP rises even further during breastfeeding, as it is also produced in lactating mammary tissue. So careful and regular monitoring is vital for mother and baby health to avoid dangerously high and low calcium levels. We welcome the new guidelines and thank all its authors and patient experts for their contribution. We feel that many topics have been well revised and updated and look forward to further research to address others in the near future. We hope that this guideline will inform patients and doctors alike, encourage better collaboration and further greater understanding of our condition.
Thank you very much to the speakers with this comprehensive and very interesting overview. We do have questions, and I suggest, with respect to the time, that we just invite all speakers and that we immediately can start off with the Q&A, where all speakers probably will be involved. There is a question, I think, to Jans Bollerslev. There is a question, a 3.5-year-old daughter suffers from ADH type 1, and they want to reduce the calcitriol, and they wonder whether it's allowed to change the calcium supplements with respect to the advices that are there now in the guideline.
So the guidelines is only directed toward adult patients. So we have no recommendations for treating children.
Thank you. There is some questions on the quality of life. So I think for Heide, there was the difference in quality of life between surgical and non-surgical patients. Is that really true? There was or can you maybe elaborate a bit on the hypothesis, what the cause of it would be if there is indeed a quality of life difference?
The theory about this is that they are just more used to it. So it's not that they don't have it, but they are just more used to it. This is just the idea. The decrease in quality of life probably is the same, but because they are more used to it. This they don't sometimes really in some of our patients of ADH1, they did not really realize that the complaints they have has anything to do with their disease, because they have their disease perhaps starting from, or they realized that they were diagnosed with 12 years or some even after 20 years of age. And so they are so used to having these symptoms that they think everybody has these symptoms. So this is what one patient of me said. She said, I thought everybody has this pain. So it was not, while doing sports, for example. So this is at least what's, so I don't know how to better explain this. Perhaps Natalie can add some.
Can I step in? I totally agree with Heide. For us, when it's post-surgical, we have a reference between the before and the after. So we really can tell how we were before and after. What we can also say with post-surgical, it's that the body has a capacity, which is quite extraordinary over the years, to get used to the symptoms, even post-surgical, and the mind kind of like tries to, it just becomes part of a life. We just become us as well, like that over the years. And so for those that have it from birth, it's just their life. So I think that that's just where the difference comes, and the body just adapts to it. It will ignore a lot more the signals. So it will ignore like this huge tiredness. We just get used to it. Just like doctors with their 24 hours.
Thank you. And I think, Jens, you raised your hand also to comment.
Yes, I'll just put in an analogy here, and that is that one of the most conservative things you can ever think about, that is your body. Your body do not like changes. And in post-surgical hypoparathyroidism, you have a change in your calcium level that is dramatic within hours. When you have non-surgical hypoparathyroidism, it develops slowly, slowly, slowly over long time periods. Thereby, the body adapts to the changes. One of the first patients I saw with hypoparathyroidism underwent or came into the clinic it's more than 30 years ago, and she had truly had hypoparathyroidism for many, many years when we suddenly made the diagnosis. She was not aware of any symptoms, whereas in the post-surgical types of hypopara, you do get the symptoms within hours. So just think about that when you have a chronic disease that develops slowly, you will not recognize the symptoms. If you have a blood sugar that drops dramatically within short times, you will have huge symptoms. Often you do not recognize the symptoms before they are getting aware. We are seeing that in endocrinology. If you again look at other diseases where we put in a substitution therapy, for example, if you are lacking growth hormone, you might not have any clear symptoms. You do not feel optimal, but you do not have any symptoms. Then you start slowly replacing with low doses, gradually building it up. And the patient do not recognize the difference before we are stopping the treatment. Then they do feel that the symptoms were there. So my point is, in post-surgical hypoparathyroidism, the symptoms comes over hours and they are dramatic. In chronic hypoparathyroidism, the disease develops over a very long-term time period, and the body adapts to it.
Thank you. There is some questions on PTH replacement therapy. So there is a question, is there a preference for PTH 34 or 84? What is the experience with paloperidotide, so with Yorvipath? And also with respect to Yorvipath, it is the question whether the kidney calcifications can regress under therapy. And I think that's for Jens and Heide.
Yes, I can start out saying that from a regulatory point of view, everything except palopec is off-label. And experience, Heide?
I'm sorry, I'm in a hotel and somebody just moved in, so you just have to comment. So you have to just comment on your experience on paloperidotide concerning what?
Well, in general, whether there's a preference for PTH 34 or 84, or whether calcifications can regress under PTH replacement therapy.
So we don't know if calcifications can go back. We actually don't know right now at all if we can change complications which are already there. What we know is that we see in the kidney function some improvement after during treatment. So this is from the studies. So, but what we know is that 1 to 84 right now is not available anymore. So it's not. You could discuss if it's better to have 1 to 34 or paloperidotide. And from the results I showed, you can see that, for example, quality of life improves from when you change from 1 to 84 to paloperidotide. And we think this is probably because it's more stable and that it has a longer half-life from 60 hours. So it's much better and a much more stable situation. So this is the experience we have, but no idea if calcifications get better or if you have so we have to wait for this actually. Additional,
Jens, go on.
Yeah, I'll just put a point in here because it can be for for people not working with PTH replacement therapy or with hypopara from a medical point of view, it can be a bit confusing. We are talking about 134, we are talking about 184, we are talking about Palopec. So the first studies work back in the 10s where they used 134. That's a fragment of the hormone, but it was given either as a single injection, having a very short half-life, meaning a very short time of action. Thereby, the concentration of the fragment came in and went up and went down very, very slow. That was, of course, not physiological. It's not how it works in the body. In the body, you adjust your PTH every minute after the calcium level. When the calcium level drops a bit, PTH goes up, and then you are getting calcium up. Then it was clear that 134 might have been better if you used it twice a day or by an infusion. And that's what the first study showed, that the more physiologic the substitution became, the better it was for clinical outcomes. That was the 10th. Then from 10 to 20, studies with 184 came in. 184 whole molecule PTH has a little longer time of action, thereby having a broader, more timely effect in the body. Again, it's not physiological because in normal physiology, you adjust all the time your PTH level. Then with Palopec, you have, as Heide said, a molecule that it's 134. Yes, it's 134, but it's linked so that it is delivered constantly and you are getting a steady concentration in the body. It's more physiological, although not still totally physiological, but you will have a steady level of PTH in your circulation, thereby adapting a more steady calcium level. So that is the best option we have today. That is a prolonged action of the fragment of the molecule, but it is working on the receptor and it does give a near to normal calcium level. That's my point.
Can I just
go ahead,
add to
Natalie.
this? This is just for the patients that I want to add. So as Jens, I don't know how to pronounce your name. I'm sorry, I've forgotten how it's pronounced. Just mention, it's always a regular amount of PTH. What will continue happening even when we are under this treatment is that when we will do more physical activity or have more social events or have anything that normally, if you have the glands, would increase the amount of PTH to increase the calcium, we just won't have that. So even when we are under this treatment, we will still have crashes if we do more than what this level is, steady level, because that's not the way the body works. The body adjusts the level. So I just wanted so that the patients do know it's not because you have it that you're not going to crash.
Heide?
Yes, perhaps to support and add to Natalie, is that we learn right now that we have to adapt. And this was one, if you look at one of the Hypopara recordings we did last year, so sometimes you have adapt doing sports. So I have, for example, a woman with Hypopara who runs marathon, a half marathon. So she has really a special way how she adds to the treatment so that she can do the sports. It is possible in some patients to do this after during treatment, but you have really try to find out how much your body needs additional calcium because PTH is not increasing, as Natalie pointed out. So this is really it's a kind of learning to know how much I need also in stress. If you do like exams and if you recover more and take again social life, you have really to learn how your body adapts and what's the best way to do it. And this is something we really have to learn, and we did not study really up to now. So there are no real data on how to adapt during stress or during the sports and things like that. So just to add on this.
Yeah, I think important points. There was also a question to which amount food-derived calcium consumption was allowed. Ida, maybe you
You
want to
you mean
respond.
how much calcium is allowed to use during treatment?
In your diet? No, in your diet.
Yes. So it's just that's a very good question actually, because some of our patients use also calcium in the mineral water and additional eat a lot of calcium in the diet, and this will change your level. This will change your calcium level. So 1,000 milligrams is the normal nutritional input you should reach, and this is also something which you should perhaps manage, and each additional calcium will probably increase your calcium, because PTH is not going down if you have like the treatment. So normally, if you would take calcium intake and we measure PTH in healthy people, then PTH would go down because calcium came with a nutrition. But this is also not reacting. So PTH is, if you're on treatment, like which half-life of 60 hours, or then it does not go down. It does not go up on treatment, but it, as well, as Elizabeth said, it's if you have too much, it does not go down. So this is also you have to be aware of. Yes.
And then there is another question. Oh, sorry, Natalie, go ahead.
The question was actually for François that I had put in the chat because I couldn't put it in the Q&A. Will you be asking it, or?
I didn't see this one in the, maybe you can point out the question for François. I didn't receive it, sorry.
So my question was, when like medicines in the approval process, some of them, and as we are mentioning, it's the PTH 134, which is off-label and has been given off-label, waiting for something official. How come, or my question is, why isn't there a way for these medications to become officially approved for our condition, when there are some that kind of already exist? They may be not perfect, but with the infusion pump, they did help a bit. And why do they remain off-label?
Thank you, Natalie, for the question. In fact, there is a way, and this route can be initiated either by one of the companies or the company manufacturing this product, the marketing authorization holder. But since a few years now, there is also a possibility for academia or non-profit organizations, research organizations, and they usually do it in partnership with patient organizations, to take all the evidence that already exists for the new use and to request a scientific advice to the European Medicines Agency or a national competent authority, asking, do you think the evidence is enough to obtain what they call a variation, that is adding the new use to the indications for which the product is officially authorized. And there are pilots. This is feasible. There are support to academia to come forward with this data, this evidence. The limit here is if the product has been authorized years before, a long time before, probably the company reassigned most of their own regulators and research teams to other product development. So for the company, it's difficult to accept the proposal and to submit everything they need to obtain officially the new authorization. They need to invest resources, and sometimes the regulators will say, you still need to conduct this additional study, and this has a cost. And what we haven't solved for the moment is the business model for drug repurposing, how whoever will bear the cost, how to return some revenues to compensate for the additional cost. And we are still working on this. This hasn't been solved. And just to mention two projects, Remedy for All and Repo for EU. These are two projects for the repurposing of medicines involving academia, industry, and patients. And if you're interested to maybe push for some repurposing for any products for hypoparathyroidism, these are excellent resources that you can contact to submit your ideas.
Thank you very much. There is some questions about the screening of complications due to hypoparathyroidism. A specific question is are problems with the teeth a complication, or are they related to hypoparathyroidism? And there is a question also on the monitoring of the possible side effects. So what about the screening for ocular neurological complications, for cardiac complications, for the skeleton? It was, well, by one person, it was felt that only renal complications are monitored. But maybe Jens, you want to comment on this?
Yes, we have to realize that complications are different in the various patients and also in the various groups of patients. The longer you have been exposed for the hypopathy, the higher the risk of complications. We discussed just a few minutes ago that the symptoms might be more pronounced in post-surgical compared to non-surgical hypopathy, but complications are related to the time of exposure, thereby saying that patients with non-surgical hypopathy are more prone to have complications. The various complications, of course, should be looked at as symptoms are presented. We do not go in the guideline, do not go in details beyond what we have been talked about. So it's not, as I see it, it's not a question of that we are making a bucket list what you should present, but you should ideally, when you go to the doctor, you should present the symptoms that you have and that you feel is a problem for you, so that the doctor can, or the healthcare providers can look specifically after the symptoms you have. We do in the comments to every recommendation in the guideline discuss the background for each recommendation. So when you are looking into the guideline now, you will see it starts out with these 37 recommendations. But if you go further down, as Lucy did in her very nice presentation, and thank you for that, Lucy. If you go further down in the guideline, you will see the reasoning, which is an updated review search for the background of each recommendation. Thank you.
And with respect to the problems of the teeth?
The problem with the teeth is related to the exposure time, and especially, as I see it, related to non-surgical hypopathy.
And with respect to medication, do you think that conventional therapy, or maybe Heide can also answer, that there's a difference between patients on conventional therapy or PTH replacement therapy with respect to the screening of complications?
We do address that in the guidelines. So it's just go in and see. We have to take into account that the experience with replacement therapy is so far not very long, because systematic studies we have in the clinic, we now have Pelopec, but the systematic studies have not been run for so long time that we do have a lot of data so far. And the previous studies on the two molecules, 134, 184, were also not running so over a very long time point, and thereby we do not have solid data on that. And we have to acknowledge we will not get solid data on everything. We will not. This is orphan diseases, or is an orphan disease. and when I'm talking about diseases, that's because I discriminate between post-surgical and non-surgical, and thereby we shall not forget being clinicians and having a relationship where we are focusing on the patient. And I think we do address that, and we do point to that in the guideline, that every patient should be looked as an individual patient, not a group of patients. That we have this individual focus where we are trying to look in this specific, and I think that's actually is right for every patient in the clinic, not just hypo-PT patients. But what are the targets here? It's individually to define the targets. Also have to take into account that hypo-PT is a continuum from very, very severe symptoms to patients having almost no symptoms. And then we are looking at, is there a total PTH lack or is there a partial PTH lack? And that's quite another discussion, and something we also address in the guideline here. Never forget that there might be some kind of recovery. Always look for that when you are monitoring patients for a longer period or over a long time.
Yeah, with respect to that, I would just like to ask, and then I come to you, Heide. There is also the question whether, or actually what is recommended for borderline hypoparathyroidism with just below normal levels. With the background question, does your body get used to calcitriol and will it then just shut down the PTH and cannot make it PTH in the end anymore? That's another question for you, Jens, what the recommendation is, and then I come to Heidi for
the recommendation. I don't think that you can shut down the PTH. You can lower the PTH, you can suppress it, but you cannot get rid of it. What I'm saying is that if there is a capacity, if there is a rest function, you can hide it by active treatment, but you cannot get rid of it. So thereby you have to look for it. And that's why we are saying always be aware of the potential of recovery.
Yeah, so we're not afraid of a tertiary hypoparathyroidism.
No.
Heidi, you wanted to recommend?
Yeah.
To comment, sorry.
Yeah. Just for this point, just again to explain why do we put the calcium in the lower, try to put the calcium level in the lower range of normal. This is exactly one of the reasons that if you have it in the lower range and goes in the medium range, and then you try to reduce the medication to have it again in the lower range, you will see the recovery. And otherwise, if you don't do it, you don't see the recovery. And I also had a patient, if you say, please decrease the medication and write it to the physician and they don't do it, then you have like several years, the high calcium levels, although perhaps the parathyroids recovered. So this is very important to realize that's one of the aspects, to have it like in the lower range. And what I wanted to add from the discussion shortly before, because of a lot of complications or a lot of complaints, what is very important that we realize that there might be other reasons for complaints and symptoms there are. So from our patients, sometimes patients present with a lot of other symptoms and we find out totally other diseases. I just say, so if somebody has like amenorrhea and this is nothing what normally is together with parathyroid, and you find the prolactinoma, for example, so other reasons that do this. So you still have to think that you can get other diseases, although there's hypoparathyroidism, and you always have to think, can this be something else? This is sometimes the problem for physicians who have not a lot of experience with hypoparathyroidism, or primary care physicians, that they think, oh, this will all be hypoparathyroidism and I don't have to care about anything else. So this is also a little bit like a danger if you have already a big problem, that everything is attributed to this problem. Just as additional comment to how we try to influence symptoms and complaints and complications.
Yeah, Yeah. One more, and then I'll hand over to Teodor. Natalie, there was the question, and there was a big thanks to sharing your story. Which medication in the end helped you?
Okay, yeah. I was lucky enough to be put on I mean they tried everything, nothing really worked. I was put on an infusion pump with PTH 134, so off-label, in 2017. It had a huge I'm still far from being better precisely because it's just for this amount. And I obviously use up a lot of calcium. My body just obviously needs a lot of calcium. But I'd say it really helped me. Instead of looking at 100 meters as though I was going to be traveling over a kilometer, it started looking more like 500, 600 meters, not as far anymore. And I felt less heavy, but I still crash all the time. But it did help. Did that answer the question?
Absolutely. Thank you.
All right. We have a few questions around guidelines, so I assume this is for Jens. So you've mentioned that the official guidelines are for adults, and what should we provide to our children's doctors as a basis for treatment then?
I can't and will not comment on that because we do not cover that in our guidelines. So this is for adults only. So you have to talk to your pediatrician.
Thank you. And related to guidelines as well, is there a shorter version of the guidelines for the doctors who aren't likely to take the time to read the full version?
Oh yes, there is a short version, and that is the first paras in the guideline. So far it was just published, I think, a week ago, and the press release from our society came yesterday. But if you go into the manuscript, and it's really it's possible to download it directly from the ESE website. And there you will see that the first chapter is a list of the recommendations. So if you just want to see the headlines, and that is what we are seeing in the news, it's just the headlines nowadays. It's never the background for everything. So if you just want to see the headlines, the first chapter in the guideline are the 37 recommendations. So but there will come, the society is working on patient leaflets, and that will be a patient-friendly version of the guideline.
Thank you. There are a few other questions that are related to home calcium testing, and this is also personal for me as my 3-year-old daughter has a very difficult time with blood tests in hospitals and clinics. It's very difficult. And there was this device called LAQUA, I believe, LAQUA, that was researched to be sort of pocket-sized point-of-care device. I'm not sure if it's something that would be recommended, but the community would be very interested in understanding how close we have come to being able to have calcium blood tests at home.
I'm sorry, I have no information on this, so I can't really comment on that. I know that in Italy, Andrea Palermo, they work on a device, but I'm not aware of how far they are and if it's really shortly available.
I know Tom Kozwinski in London was working on the calcium tester, and it's looking really promising, but they still don't have solid enough data. So I think from the last time I spoke to him, I think we're a little while off it being able to come to market.
Yeah, and I'll just add in France, we've asked as well several times, and maybe they're going to try and look at it as well. But I would need the others to answer more because I'm not as much in the organization anymore.
All
There
right.
is a cow tester out there, I think. I don't know if it's the same one, but there is something that exists to test calcium in cows. It's just very expensive.
And by very expensive, do you have any idea of a price range? Is it thousands of euros, tens of thousands?
It's
or-
quite expensive, and the problem is my memory is not very good, and I've been told the price, and I am sorry I can't remember. But yeah, and I think that they have it in Ireland, and I think that the Nordics have some maybe as well that they've looked into. So Teodor, we can discuss maybe after as well.
No, it's because several people had the question around this, so it seemed a
but
topic.
nothing has, as far as people have used the cow one, I think some people have personally invested in it, but it's quite expensive because their ranges are the same as for humans. And but I have no experience with it. This is just stuff that I've heard.
So I can just add in that we do not cover that at all in the guideline. And the reason is simple, that there's no validated data on it. We have heard all heard about calcium testing, the things under development, and we have heard of that for years, but there's no, when we went through the literature, and we did last year, there's nothing on it in the literature. That's the reason it's not covered in the guideline.
All right, thank you. Another question is related to blood calcium measurement guidelines. So there's a difficulty with explaining how to draw blood and how to process it in time for the calcium measurements, which are very sensitive to stay relevant. And oftentimes requests or suggestions are ignored by the medical staff. Are there any guidelines on this process?
We do not cover in the current guideline the methodology behind the calcium measurements. What we do is we do recommend using total. We had a huge discussion on that, using total or albumin adjusted calcium or ionized-free calcium. They are all well adapted in the clinic. What you have to take into account is that the calcium level in a given patient is just a measure of what your calcium is at that time point. Take analogy to diabetes. It's just a blood sugar here and there at that time, and it fluctuates, especially in hypoparathyroidism patients on first-line conventional therapy. Calcium fluctuates. So measuring it, unless you have a continuous evaluation of the circulating level, measuring it gives you only one time point. Again, symptoms will fluctuate, not necessarily according to a steady low or high calcium, but according to the changes in calcium. So if you're raising your calcium, you might experience symptoms. If you're lowering your calcium, you might experience symptoms. So often it is, from a physiological point of view, it's not the amount of calcium, rather it's a change in calcium, as in other endocrine diseases, it's a change in the hormone. And remember, this is a hormonal deficiency syndrome. It's not just calcium, it's more than calcium. Concerning post-surgical hypoparathyroidism, if you're looking at calcium levels, the correlation between PTH, the hormone, and calcium, being total calcium, being albumin adjusted calcium, being free calcium, there's a close correlation in every one of us. So if we knew what the calcium level was before surgery, we had a point that we could titrate against. But often we do not know that. And with first-line conventional therapy, we recommend having a calcium level around the lower level of normal. We do acknowledge in the 2015 guideline and in the present guideline that many patients do better if they have a higher calcium level than closing to the lower level of normal. Then we advise that we treat patients according to symptoms and the well-being of the patients. So if they do not feel well on first-line conventional therapy with a calcium level at the lower level of normal, then titrate it a little higher and accept that. With replacement therapy, when we're talking of PTH replacement therapy, we can increase the level of calcium. Again, it would be so wonderful. It will be very helpful if we have the pre-surgery calcium level, because it's quite steady over lifetime in every one of us. And thereby also we would have a time point or a point of calcium that we could titrate against.
Thank you for that. That was very insightful. I wasn't aware as a caregiver that the drop or raise in calcium is as important as the actual value being low or high. That's very interesting to know. All right. So another question is related to ADH1 patients. So with congenital type of disease, and it's related to encaleret. There have been several studies, and a recent press release from BridgeBio mentioned that there would be some progress made with pediatric versions. Does anyone have any insight or any idea about what that means in terms of how quickly we could try this out for a child?
Shall I just comment on? So just for those who are not aware of the effect of encaleret, this is like a kind of drug which modulates the sensitivity of the PTH receptor. So what it seems to, what it does in the treatment of those patients who have already a sensitivity change in this ADH1, for example, a sensitivity change of this receptor, and therefore low calcium levels, the drug increases the sensitivity, decreases the sensitivity, calcium decreases the sensitivity, and PTH would go up and calcium will go up. So the hope would be that, and there's some research that, also in other kind of PTH diseases, that perhaps also in those PTH would increase and normalize the calcium levels. So actually, I'm not aware about a pediatric study right now. This might be my reduced knowledge on pediatric diseases. So this is just that there's a hope that encaleret would be available during the next years for patients with genetic disease, and then perhaps also for pediatric patients. So this is, but I'm not aware of the study. Perhaps Jens or somebody else is aware of the study.
I cannot comment on it. We do mention encaleret in the guideline as a drug under investigation, and as Heide says, this is not a PTH disease. It's per definition not a PTH disease. It's indirect PTH disease. It's an indirect disease. So the mode of action is quite different from, and it's including another receptor. But there is, I think I should stop here.
Okay, Teodor and Elisabeth, I think that the time is gone. we really don't want to keep all the patients and more than the time that is allotted, because then it could become difficult for them to follow the sessions. And therefore, I think with Tanya, I would like to really thank everybody for being here. We already have more than 100 people connected to the webinar after 3 hours of work. I think this is a fantastic number. Hope that everybody really enjoyed the 2 sessions that were very interactive, a lot of questions. Maybe some questions remain to be answered. So I think that the speakers could be willing to respond to the remaining answers in writing, because I think the questions are all interesting, are all very stimulating. We had a lot of time for discussion. I think this was very good in the plan of today, because one of the main goals of this kind of meetings is to exchange information, to foster the dialogue between patients and clinicians. And I think that this today was fantastic. Really, we found a formula with a lot of time for discussion, a lot of time for questions. And I think that the patients made very, very specific and informative questions. And I think this is also reassuring that we have a community that is really very, very strong and very motivated to improve what is our patient situation. Tanya, would you like to close the meeting on behalf of all the patients?
Yes, thank you. Yeah, thank you to everyone who participated. I'd just like to say that we have recordings of previous sessions. So if there's anything you'd like to revisit in terms of symptoms, treatment, adaptation of treatment, please do check out our videos from the last 3 installments of this forum. And we are planning on having one next year. So if there's anything that you think we should cover that we haven't covered before, please do let us know via our websites, for example. Just write us a message, and then we can take that into account for next year. So thank you, everyone, for the organization, of course, ESE staff. Thank you very much. And thank you to all the hosts and panelists. And see you next time.
Very
Bye.
good. Thank you. Ciao.